Hello, I have the pleasure of introducing Dr. Larry Amsel today. Dr. Amsel is an associate professor of clinical psychiatry at Columbia University, New York State Psychiatric Institute in the US. Dr. Amsel is the associate director of the Global Psychiatric Epidemiology Group, GPEG, where he applies decision science tasks in psychiatric research and explores the role of biological mechanisms and decision sciences to a range of outcomes, including suicidal behavior. Dr. Amsel, known as an outstanding teacher, also trains clinicians, especially pediatricians, throughout the US in psychological assessment and treatment, having trained thousands of community clinicians in evidence-based treatments for PTSD and complicated grief. He is a co-investigator on the Guyana Wellbeing Studies and co-investigator on Columbia University GRIT training program, so the Guyana Research and Injury and Trauma Training Program. So Larry, I'm going to turn it over to you to talk about assessing and managing suicidality.
Good morning. All right. We will get started in just a moment. This is a module. This is a talk given for pediatricians or family doctors. It's an introduction into how to assess and manage suicidality in the primary care setting. It's not meant as a complete training in suicide, but as an introduction to managing it, because we know that a lot of primary care clinicians, pediatricians, family docs, nurse practitioners, etc., are actually facing a lot more mental health issues. And one of the things that they're very concerned about is that it's never been part of their portfolio to be concerned about suicide, or to be the professionals dealing with suicide, which I have to say is probably a major shortcoming of training programs for family practitioners, pediatricians, nurse practitioners, and even straight nurses. Because it's a life-threatening condition, and it's something everyone should know about. I was thinking about analogies. It occurred to me that everyone going through any training in which they're going to be clinical facing has to take a course in at least basic, usually advanced life support, but at least basic life support. Things like first aid, basic first aid and basic life support. And so this is really also should be basic life support. Imagine people going through nursing training or psychiatry or a medical school training and not knowing what a myocardial infarct is, not knowing what a heart attack is. It would be considered outrageous. So I think the same should be true for understanding suicidality. I think it's an area that causes a lot of anxiety. And it's interesting because in addition to being on the side of preventing suicide, or put it a different way, one of the ways that I actually end up working on preventing suicide is that I'm a consultant in legal cases that involve suicides that have happened, and I'm called in as a consultant to see whether or not the clinicians are responsible, whether or not they did malpractice. And I think a lot of clinicians are very much worried about being sued. I mean, they worry about losing patients, but they also worry about being sued. And so I incorporate the kinds of things that you need to know, because there's no special issue about the medical legal issues out here. If you do good care, then you don't have to worry about the legal issues. It's just a question of doing good care. I see a lot of very, very bad care that goes on, and people who have died in hospitals or immediately after being discharged from hospitals, or in outpatient settings where sufficient care is not being taken. So I don't know what that ding dong is. Does that mean someone's joining, or what is the
Yeah.
ding dong?
Yeah, that's someone's joining, yeah.
Terrific. So let's go. What are we going to learn? We're going to learn to identify suicidality and its risk factors, have a discussion about suicidality and the management of suicidality, select and discuss safety plans and treatment plans that match, that match the severity of of depression, because depression is a very big risk factor. We want to understand the boxed warnings that have come out in regard to SSRIs, which many clinicians are familiar with. And we want to discuss the risks and benefits of antidepressants. Do they increase suicidality? Do they decrease suicidality? It's been quite confusing in the general press regarding those kinds of issues. So suicidal ideation, when we talk about suicide, should be many categories, but the easiest thing to think about is suicidal ideation, a suicide attempt, and what's called completed suicide. And these are very different things. Suicidal ideation is thoughts of wishing to die. Suicidal attempts are, of course, when someone takes an actual action with some intention to die. In other words, that's not just cutting yourself. And then, of course, completed suicides are tragically when people actually end their lives. But there is some confusion, because there are things that show up in the emergency room that are classified as accidents that are actually suicide attempts, where people have denied, well, they drove the car very quickly. So there are accidents that end up being suicide. And then there are accidental completed suicides. In other words, where people are thinking about suicide and they start taking an action, they'll take a bunch of pills or do something without full intention to die. And they die because they are not familiar with how lethal their actions are. So I think within psychiatry, within mental health, suicide is one of the most complicated aspects, because it involves what are your intentions, what are your motivations, it impinges on all of us. We're all living our lives, and the idea that some person found their life so unacceptable that they wanted to take their own lives. When most of us, and evolution, depending on your theology, evolution or the great creator has created us with very strong desires to live and very strong self-protective mechanisms. So it seems to be one of the stranger behaviors in human experience. This statistic says that 17% of high school students, this is in the United States, have suicidal ideation, and that went up to 25% during COVID. I would say that is a gross underestimate. Thoughts in times of, would everybody make sure they're muted, because I'm getting some distracting things. But everybody please mute, or whoever is in charge of the technical of the Zoom, if they can mute everybody. Does anyone know what the source of that is? If we could, any way that we can cut that distraction off? If not, I'll just speak a little louder and we'll go on. But if somebody could pay attention to that, I appreciate it. High schools, the percentage of high school schoolers that need medical intervention, in other words, that their suicidal ideation is so severe or they made an attempt, it's 2.4, and the rates are rising among African Americans and minority groups to match white groups. It used to be one of the paradoxes, we thought of it as a paradox, that Blacks in America had lower rates of suicidal ideation. One idea about that was that because in those communities faced greater hardship, people had greater resilience to hardship, was one of those thoughts. And but it was unclear. But what we do know is that the rates are rising right now among minority groups. Then there are lots of risk factors for suicidality, known and unknown, and that's the reason we're doing this huge Guyana study, is to try to ascertain what some of the risk factors are for suicides in Guyana and in general, to understand risk factors, universal risk factors associated with suicide. But the things that are factors involving an imminent risk, in other words, when you have a patient in front of you, are they at imminent risk? Is there a danger that they might take an action quickly in the next days? The things that one has to think about, we're going to talk about. One of the things to do is it's always important to talk about suicidal risk in the face of depression, severe anxiety, or if the person is an impulsive person. Severe substance abuse is also one of those acute things. If there is a specific plan, so it's one thing to say, and you'll ask many people, and I'll often ask my people when I suspect that they're suicidal, I'll say, do you ever go to bed at night and just look up at the Lord and say, Lord, take my soul, take me home, something like that. So I try to ask the question in a very gentle way, to start with, asking them about whether they have such a wish. That's called the passive suicidal ideation. That means they have no plan or intention to end their lives, but they would be happy if their lives ended. And that's called passive suicidal ideation. So it's important to ask about that. But it's also important to ask about any plan, because once it's moved from that stage to actual planning, and suicide is in some ways no different than other things. You might, and this might seem like an odd analogy, but it's very important that we understand suicide in the context of how humans make decisions in general. I introduced this idea 20 years ago that we have to think about decision making in suicide, and people thought it silly, but now people understand that that's actually absolutely correct. You have to think in terms of how people make decisions in general. And so, you might wish to have a car, but you don't have any plan. Then when you're ready, you make a plan. Oh, I'm going to go get this car. So once you start making a plan, that means it's much more serious. We know that from suicide research, but also from decision-making research. Turns out, interestingly enough, that suicide also runs in families. There seems to be genetic components to it. So that's an important aspect. It is both a mind problem and a brain problem in the sense that there are biological aspects to suicidality, and that some of those biological aspects can be inherited. LGBTQ persons are at higher risk. Unclear whether they are higher risks because they're under more stress. They face a lot of social stressors, or whether or not there is other reasons for that. Perhaps prejudice, bias against them might contribute to that, but we do know they're at higher risks. And other risk factors we're going to talk about in a moment. So what do we do? Well, we strongly suggest that people use a suicide screener. The ASQ is the Adolescent Suicide Questionnaire. The ASK is developed by National Institute of Mental Health. More recently, there's also a Columbia screening tool that's out there that's been very popularly used. And then there's a suicide evaluation screening process and a safety plan. These are the ones we're gonna discuss, and then I'll mention things that are, because these are the ones that we're recommending for today, but there are other ones that are out there. It's very important. One of the things that when I'm asked to consult on these cases, one of the things that has become very noticeable and a very important thing is that when a psychiatrist, and they're not so much the younger psychiatrists who are better trained about suicide, but the older psychiatrists who have had a lot of experience have come to the mistaken idea that they can rely on their experience, that they can rely on their intuition when it comes to assessing suicidality. And I cannot tell you how many charts I have reviewed in which the clinician writes down, I have interviewed the patient and I am confident that they are not suicidal, right? I am clear that And it's based on their own intuition, and people are based on intuition. And when I trained, that was pretty much the way it was done. You have to become an expert and you sort of judge people. I looked into Putin's eyes and I saw that he was a good man. The famous quote, a former American president. So you can't do that. You can't look into somebody's eyes in those. You've got to use these screening tools, because these screening tools have been designed to actually, in an evidence-based way, capture the suicidal risk and separate those who are at higher risk from those who are lower risk. Is it absolute? No. But when it comes to suicidality, we're dealing with probabilities, and you've just got to increase your probability that things are safe. Now, when talking to adults, I recommend that you be very straightforward about asking about suicidality. Firstly, there used to be a myth in the field. I don't call it a myth, but it was a clinical concept within the field that if you ask somebody about suicidality, you might be putting an idea into their mind. What I always tell my residents and my medical students is that's no more likely than the concept that if you ask an adolescent about sex, that you're giving him an idea that sex might be interesting to him or her. Not the case at all. When somebody is in depression or is having a great deal of stress, suicide is in their mind. Suicide comes to mind. And think about it. Why does suicide come to mind? Suicide comes to mind because as human beings, we are constantly thinking about the future and making plans and thinking about it. And if my future looks incredibly bleak, or if I'm in an unbearable amount of pain, one of the things that comes to mind is I could stop this pain by stopping my life. And that comes to your mind as a potential action. When you stop to think about it, we're constantly thinking about potential actions. There are people in the room who are thinking, oh, damn, I came into this talk, but it's so boring. Maybe I should leave. So we're constantly thinking about plans, and people who are in pain always have suicidal ideation. Doesn't mean it's a plan, but it comes into their mind. And I'd also point out to you that in common parlance, in common language, people will use references to suicidality. Oh, if I fail that exam, I'm going to kill myself. If this doesn't work out, I'm going to kill myself. It's a common thing a common thing. Now, that is not a suicidal ideation, obviously. But I just want to point out to you that it's so common in the language because it is, in times of stress and in times of pain, it is on the menu. It is on the options menu in human beings' lives. Now, how do you talk to kids? So that's with adults. Don't worry about ever putting an idea in their head, nor with kids. But how do you talk to kids about it in a gentle way? And do you want to kill yourself is a little too hard to start with. So what you want to do is you say something like, sometimes kids feel so low that they wish they were never born. That's a great question, you see. Now, what this does, notice the elements of this question. What this question does, first of all, it says sometimes kids, which means I, as a clinician, have spoken to other children like you, and they do X. And that's called normalization. And it's actually a good technique when you interview children and adolescents in general, is you let them know that the question you're asking about them is normal. In other words, that you're aware of it and it's a normal thing. It's called normalizing, right? So you similarly, when you're asking about drugs, alcohol, or sexual behavior, you say, some of the other kids that I talk to have told me this. What about you? So that's a good way of introducing the topic. Sometimes when it gets so bad, people wish that they were dead. Tell me about you. Okay. Have you ever had thoughts about just ending it all? How do you think about doing it? And again, notice, how do you think about doing it? Don't ask a 14-year-old, what is your plan? It doesn't speak to them, right? So you want to use language that is inviting a person to open up and talk to you. How often do you think about it? How close have you come to doing something? Have you ever taken any steps towards ending it all? Okay, so you can see the form of these questions. And the nature of these questions. Have you ever done something to hurt yourself or tried to kill yourself? Okay. And then also, it's very important to give positive feedback. Many of you might be familiar with the parent training concept of catching a child behaving, right? Instead of focusing on catching a child misbehaving, you try to catch a child behaving. That means to say that you find instances in which, as you're working with a child, as a parent or as a clinician, find instances to find things to have a positive feedback for. And the same thing goes here. As you're talking to a child and adolescent about these issues, you say, I'm so glad that you're talking to me here. I'm really, really glad that you're willing to share this stuff. The second half of this question is, what stopped you from acting on those thoughts, is a related question. But as you're going through these questions, reinforce that. So here is the suicide screening tool. And depending on where you live, what the conditions are, this is getting to be more and more of a universal thing. But for the sake of this talk, we'll talk about the notion that you have some reason to worry about suicidality. I don't know that you're necessarily going to use this as a universal screening tool for every clinical encounter that you have. But let's assume that there was some reason why you had to be concerned. So this tool will help you decide if that concern is strong, if you have to worry about that concern, and what to do about it. So think of it as a triage tool, okay, where you're either going to decide that, like in triage, you're either going to decide, well, suicidality is not an issue here, or you're going to decide suicidality is such a serious issue that this child has to go into a protective area, like an emergency room. Or there's something in the middle where I can manage this child without hospitalizing them, but I have to do something in the middle. And we're going to talk about putting a plan in place. So again, it's a triage, not a problem, a severe problem requiring immediate attention, or somewhere in the middle where I can manage this child as on an outpatient basis, but I need a plan. So what's the question? In the past few weeks, have you wished you were dead? Yes or no? In the past few weeks, have you felt that you or your family would be better off if you were dead? Why is that question there? Well, all these questions there because they've tried bunches of different questions and did research on this. This is an evidence-based scale. It's not somebody's just, idea of what would be good questions. These are questions that have proven to sort people out properly. And the reason that we ask about, do you think that your family or others would be better off without you? It's because for most people, there are exceptions. Kids who are being abused, their family is not positive for them, obviously. But for most people, one of what we call the protective factors, one barrier to committing suicide is the fact people don't want to hurt their parents. People don't want to hurt their family. So families tend to be a very protective thing. I got kids. I'm not going to kill myself, doc. I got kids. Or mom and dad would be so distraught, so I can't ruin their lives. So it's usually a protective factor. But in severe suicidal thoughts, people start getting the idea that they are such a burden to the family that the family would be better off if they weren't there. And that is a very serious question. Because it does two things in terms of motivation. First of all, it takes away the protective factor. It's like, no, it wouldn't be so terrible for them if I killed myself. And number two, it simultaneously takes away the protective factor, but it adds to the motivation as well. So it goes from the negative column to the positive column in terms of pushing you towards suicide. It's not only that they wouldn't be hurt, it's not a protective factor. They would be better off. I am doing something altruistic. I'm helping my family. Now, in some of the bizarre cases that you guys have read in the newspaper over the years, for example, where we have mothers oftentimes right after giving birth, and we now understand that they're in postpartum depression or postpartum psychosis even, and you'll hear these stories where a mother drowned her kids and herself. And very often, if you go back and you understand the case properly, it turns out that those people exactly have this concept that somehow we would all be better off. It would be better for the family, it'd be better for the world if we were all gone. So that is a dangerous, very, very dangerous concept. So you ask that question. Then you ask the question about a practicality. In the past week, have you been having thoughts about killing yourself? Now, again, this is not passive suicidal ideation. This is much more that this is what we call active suicidal ideation. Thoughts about killing yourself. Okay. And then the question is, have you ever tried to kill yourself? Okay, so we get to all the important aspects, which is a past history of suicide is a very strong indicator. So let's see how this triage tool works. If the patient says yes to any above the questions, you then ask, I'm sorry, that moved by accident. You then ask the following: are you having thoughts of killing yourself right now? And if so, please tell me what they are. So if there's any yes on any of those, then you go to question number 5. Now let's see how we work with this. If the patient answered no to all the questions 1 through 4, the screening is complete and you don't have to ask question number 5, and no intervention is immediately necessary. Because, again, you have to know that there's no contradictory information. It's not like the kid says as the mother comes in and says, he told me differently. But if these questions are answered honestly, past few weeks you had the no thing, past few weeks you didn't feel this, in the past week you've never had those thoughts, and you've never had a suicide attempt in the past. So that kid goes into one of those 3 lanes that we call in the triage lanes. That kid does not need any further thing. They go into the very low risk category. If the patient answers yes to any of the questions 1 through 4, or by the way, refusal to answer, this is not like it works in American courts where you're allowed to plead the 5th, and you can say, I don't want to answer that question because it may incriminate me. And then in American courts, if someone says that, the jury is not allowed to assume that the answer was the worst case scenario. But in a suicide questionnaire, anybody who doesn't want to answer a question, you assume the answer was the worst possible answer, because that's the safest thing to do. So anyone who wants to refuse an answer, sorry, that answer will be scored as the worst case scenario. So if a patient says yes, then you ask them question number 5. And if someone says yes to number 5, that is what's called an acute positive screen, and that's an imminent risk. So you have then find yourself in a situation with an imminent risk. Okay. So let's just go back and see that there's been some yes answer. Have you had thoughts of killing yourself right now? If a person has thought of killing themselves right now, that's an acute risk, and that person must be evaluated either in an emergency room or by a mental health professional before they are allowed to leave your office, assuming this is taking place in an office. If it's taking place in a clinic, you may need to move that individual to the emergency section of that clinic or hospital. If they say no, so it's not an acute screen, then the patient requires a brief suicide safety assessment, and we'll talk about that next. So that's the 3rd lane. So if they say, again, all no's, okay, I've ruled them out. A yes to one of those and a yes to 5, they need emergency treatment. A yes to one of those questions, any of those questions, but a no, saying I'm not immediately thinking about it. Then you go on to these questions. First of all, you praise the patient, as I mentioned to you. And you say, thank you so much for talking about it. I'm going to follow up. I really appreciate your responses, etc. And then you go through this worksheet, which you'll see this is very free and publicly available from the NIH. So you can download these and have these available to you. And you ask them about any kind of frequency of suicidal thoughts, about suicidal plans, about past behaviors. Then you check in on these symptoms. Okay, so this is, again, the middle ground where you haven't sent them to the emergency room, you haven't sent them home because they're great. You are now doing an assessment and in the middle to see if they are safe. Check impulsivity, hopelessness. You just click off all of these things, and then you which are symptoms, and then you look at social supports, which are protective factors, support networks, family situations, etc. Okay, so when you've done that, then you'll have a sense of the patient's suicidal situation, and that will help you sort out whether or not those questions push you in the direction. Because remember, you're in gray area, right? We said there's the white area where they're safe. There's the area where they're definitely a risk, but you're in the gray area. So by asking these questions, you will get a sense of the level of their suicidality. If something in those questions is not alarming, doesn't push you over, then you're in a good position. There's some suicidality going on, but nothing that's an imminent risk. And then what you want to do is make this safety plan. And I'm going to talk about the safety plan in a moment. And here is the template for the safety plan. And let's go over this in great detail. But I'm going to back off and repeat this. And I know I'm repeating myself, But I also know that this is an area of great anxiety. And so it really helps to say this over again. Someone comes in, I'm worried about their suicidality. So what I want to do is I want to triage. I want to put them in one of three categories. I'm going to ask them those first 5 questions. And as a result of those 5 questions, I will either decide one of 3 things. Number 1, they're safe. It's not a suicide situation at all, and I don't have to worry about it. Number 2, they are in an acute suicidal crisis. They must be seen in an emergency room and must be evaluated by a mental health professional. Situation number 3 is the gray area. I'm not completely sure. There's some suicidality. There's no immediate suicidal plan. In those situations, I do a deeper assessment to see if that deeper assessment pushes me in back into the direction of, no, this really is an acute suicidality. It just wasn't obvious. Or it says, no, this kid has some suicidality, but with help, he can manage even outside of a protected hospital situation. And if you come to that conclusion, then you do the patient safety plan, which is that you get the patient. Here it is, another example of this. And again, all of this is downloadable from the NIH site. So let's go over what the steps are in putting together this plan. And before I say that, I want to distinguish this plan from something many of you may have heard about, which is the suicide contract, which used to be a thing that when back in the day when I trained, there was this notion of a suicide contract in which you contacted the patient. The patient agrees they'll not hurt themselves, or they agree if they have an impulse to hurt themselves, they will actually call you. And it turned out that that was not helpful. So why is this helpful? Because this is very, very different. This is not asking a patient to make a commitment not to hurt himself, which is very hard for anyone to do, because it's one thing to make the commitment today, but what happens when I'm in an actual stressful situation? My decisions change completely, right? So that's like that kind of a commitment. It's like making a commitment to diet. It's fine to say I'm not going to have any more ice cream until you walk past that unbelievable gelato stand. Well, so so your pre-commitment isn't going to make it isn't going to help. What this is, it's a plan. This is not it's not a contract with a clinician. It is a multi-step plan to help the person deal with a worsening crisis. So as they're leaving your office, they're not in a suicidal crisis, they're not feeling terrible, or you would have sent them off to further care. But you want them to anticipate and be able to manage, what happens if some crisis comes up, some bad mood comes up, girlfriend gives them a hard time. So step 1 is to recognize the warning signs. You have people recognize, what's your experience? When do you start thinking about suicide? What are the warning signs for you? And when do you know that the safety plan needs to be used? So this is also think about this behaviorally. This is a wonderful idea, is that you have the person, really think about this. And many people say, I never thought about it. I just get into those crises. But here's what it is. My father, he comes home from work and he can just push my buttons. He starts asking me about my homework, which is okay. Dad asked me about my homework, but he asks me about this and he keeps driving it home, or he asks me in a critical way. What are the things that can put you into that crisis? Being aware of that, as you can see, is such a great thing, right? It's so great. Step 2, what are your internal coping strategies? What can you do on your own if you become suicidal to help yourself? How likely do you think that these steps can help? So you ask people for what their internal coping strategies are. And this is not involving anybody else. This is just themselves. For people who are religious, sometimes this will be a faith-based thing. Sometimes they'll say, well, I'll say a prayer, I'll say a prayer. I'll remind myself that Jesus loves me because that's part of my life. For kids, it might be a best friend that they think about. This is not yet getting in touch with somebody. Or it might be a favorite activity. And I can remember, I love going to the beach, and I'm thinking, next week I have a plan to go to the beach with Jimmy. So that's even a small thing like that. Those can be internal coping mechanisms. Breathing exercises are very helpful here. Relaxation exercises, if people have learned these in cognitive behavioral therapy, or if you teach them, Doesn't take very long to teach a young person how to do a breathing exercise to calm them down. So these are internal coping strategies, and you write them down. Again, this is all going to be in a plan that the individual has with them. Where did step 2 go? Oh, I'm sorry. Step 3 is social contacts. Who might distract you? And what are the social settings that take your mind off your problem? So maybe you'll go to the gym, and then you happen to know this particular gym, there are pickup basketball games that you can get involved in, or there's a friend, or a girlfriend, or a boyfriend, or somebody who helps make you feel better. Now, this is socializing. This is not having to do with family yet. Number step 4 is going to be with family supports, but this is social supports in your life. So, as a second step, what social contacts can you use to distract you? You've tried the internal, maybe that's helped a little bit, maybe it's helped a lot, but also we encourage you to get in touch with people. People tend not to injure themselves or suicide. There are exceptions to everything, but they tend not to do it around other people. It tends to be something that's done alone. So encouraging people to be with other people, to get in touch with friends and things like that is safe, both because tends to make them feel better. It's a social support, and because it's less likely that they will do a harmful, injurious thing to themselves in a public setting. Okay. Step 4 then is other kinds of social contact, family members or friends who may offer help. So this is people who are, it's not just a social contact, but these are people who know about your suicidality and specifically can help. That's why it's a separate step. The first one is, oh yeah, she's a dancing partner of mine. Now we can go practice our dance moves together. Or he's a basketball player, and there I am stereotyping people by their activities. But that's just the step 3 is contacts that are not sort of clinical. They're not aware of your thing. Step 4 is about family members, friends, and uncle, or people who know about your situation who can be helpful. Who could you contact for help during a crisis? Now, I always say when the person is filling out this form and writing down who could be helpful and who could be supportive that you can talk to when under stress, this should be somebody who knows their situation. So if they're putting down someone, if they're putting down, my good friend Joseph, and you say, look, does Joseph understand your situation? For step 4, it has to be somebody who understands their situation. Okay. Step 6 is contacting professionals and agencies. If this stuff doesn't work, right, then who are the mental health professionals that you should identify that are on your list? It's not a good idea that people start thinking about this when they get into the crisis. We want them thinking about this from the very beginning, right? So we want that. That's why we have the plan is you have that number written down. And sometimes we'll tell people, look, if it's severe, forget steps number 2, 3, 4. Go straight to this. If you feel that it's severe, go straight to step number 5. But in the lighter cases, see if you can get the thing under control. And then step number 6 is not something that happens in the immediate thing. Step number 6 is something that happens ahead of time, and that is that you cleanse the environment of means, making sure that you get rid of guns. Yes, sometimes in the case of someone who has said that their risk factor involves knives, you might have to get rid of some of the knives in their immediate area. So whatever turns out to be, a lethal means for them, you want to reduce that in the environment. Give me a second. So that's step number 6. And then I'm sorry, there's step number 6. And so when you have a chance, I want you to go and review these things. Again, download these things from the National Institute of Mental Health. These questionnaires are all available to you. So review them and be prepared for them. and understand that the basic steps here again are involving you doing the triage in the case the kid is in the middle case. You set up this treatment plan. They have it written down. It is written down and they have that piece of paper with them all the time. So if they get into a worsening crisis situation, they can consult that paper and they have committed to you that they will use that paper to self-soothe themselves and if necessary to contact you. And then you can feel not 100%, I never feel 100% secure, but you can feel comfortable that child can go on and be safely monitored. And what you want to do then, of course, is two other things. Make sure the parents are involved. Sorry, I didn't say that, but it's kind of obvious, but the parents need to be involved as well and be aware of all of this, and they need to be involved. And you want to see the child back in a week maximum, at very least making a phone call and checking in that their situation has not worsened. So I have a few, so that summarizes the piece on how do you evaluate a suicidal situation in the office. I have a few more slides on the boxed warning, but I see that we're at 8:40, so I'm wondering if I could take a few questions. And also, do I have all the way, is anyone in here from the conference who could tell me, do I have all the way till 9 o'clock? I know some of these talks are 45 minutes.
So you have the break that we have is at 10:30, so it would be 9:30 your time. So we can.
Oh my God! So I see. This is a double session, sort of. Okay, so I actually have plenty of time. So let me take questions. Let me take questions now, and then I'll do my slides on the boxed warning, because that's a whole other. That's a related issue. I like to talk about the boxed warning in here because I think usually you hear about that separately from hearing about the overall suicide risk, but I like to put them together. But let me stop here and take questions from people about what they've heard so far.
So if you're in the
Megan, thank you for the clarification.
So if you're in the chat, you could either send your questions or unmute yourself and speak. And we also have a pretty packed audience here. So if anybody has a question from the audience, you could ask it. If it's difficult for him to hear you, I think the microphone is over there, so you could just move a little bit closer.
And Megan, you'll monitor this for me, right? Because
does anyone have any questions from the audience or from the Zoom group? Yeah. So I have a comment about the suicide safety plan, because we actually train interviewers to do that in the Guyana study. And a lot of times it'll be the same person, like their social interaction person will sometimes be the same as their person that they feel comfortable sharing with. And that's fine. It could be, there's some of the people will overlap between all of the groups. So that's just something to keep in mind too, because it was very confusing for people when I first trained them on it. But it's a really great tool for intervention, and it's great. You can leave a copy with the person, and you know that's a lot for them to have. It's essentially a plan for reducing their suicidality that you've worked out with them. So it's a great resource, and I sent the link in the chat for anybody who is online. And then if anybody wants to come up to me here, I can show you the link online as well afterwards. But it is a really great resource for people to use.
And thank you very much. Those are very helpful questions, and that's a very, very useful comment, Megan. Thank you. In other words, between those steps, sometimes people get hung up on different social contacts and contacts of family members. And as I mentioned, step 3 is intended to be people who are not necessarily, people who are just going to pick up your mood. They're not necessarily people who know about your suicidal thing. And step 4 is family members or close friends and stuff who do know about it. But you're absolutely right. Don't get hung up with that. Those can overlap. That's fine. It just gives me 2 different kinds of opportunities. But you said it best. It's very easy for that to overlap. I've also been known in teaching situations like this that when we don't have any questions, I will turn around and start asking the audience questions and putting people on the spot. So I just want to encourage you that you want to avoid that because
Does anyone have any questions? Front row? You guys look like you have a question.
Well, hi, Dr. Amsel, it's Aziza, from Columbia. I wanted to just say that,
Can you hear Aziza?
I can't.
You can't?
So not everybody is on the screen, right? Notice that people who are in the room, I won't see them, right? I have no visual. Okay. Go ahead, please, Aziza. No, that's okay. Megan, I don't have to see anybody. I just wanted to understand.
hi, Dr. Amsel, it's Aziza from our group. I just wanted to say that, what you were talking about in the beginning about not actually, sort of like as a clinician looking at someone and making a guess as to how they were feeling or just an assumption of like a good hunch. Like that was a very and how that can be futile. That was a really good point for me, and how you can ask certain questions that make it adaptive, like it makes maybe a child feel as though they're not alone in feeling what they're feeling. That really hit a point for me. So I thought that, so I thought that was really useful. So thank you very much for that.
No, that's thank you. Thank you for reinforcing that. And that's, those are two quite wonderful points. And I would also point out to the clinician that it's a great relief off your shoulder, and it's a great unburdening when you realize that you don't have to have a Superman or Superwoman intuition, and it doesn't rely on your thing. My God, when I trained, it just relied on our on our best guess. What a burden that was. Now I have questionnaires. I use my own questionnaires. I use my own clinical skills, of course, in asking questions. But I have a questionnaire that guides me, and I see which questions are with an evidence-based, evidence-based system that puts people into a high or low risk category. So it's actually great relief. It's a much safer situation. It's a great relief for clinicians to not have to be mind readers, because clinicians are not good we're good diagnosticians, but we're not good mind readers.
We also, I'm thinking, we also have a different question from the chat. So this is more about, the therapeutic interaction and coping with your own response to the patient. So how can we as healthcare professionals, this is coming from Sharisa Stevenson, how can we as healthcare professionals prepare ourselves for encounters with patients presenting with suicidal ideations? Knowledge is needed, yes, but how do we prepare ourselves mentally, especially if we have also had a history of these symptoms?
It's a wonderful that is a wonderful question, and a very insightful and thoughtful question. And the answer is that it's very much like anything that goes on in the clinical encounter. Clinical encounters all have this aspect, right, where this other person is coming to you because they are in some kind of pain, or they are in some kind of trouble, right? And I have to meet them in a way that has these very contradictory elements. On the one hand, I need to be empathic. That means I need to be aware of that pain. I always stress that empathy does not mean I feel the other person's pain. If you try to feel everybody's pain, you want to understand their pain, but you don't have to feel. If you try to feel everybody's pain, you will be worn out very, very quickly. The surgeon does not need to cut himself. The surgeon only needs to know that the patient needs this healing, right? So he doesn't have to feel the same pain. So when the real meaning of empathy is that you understand where the patient is at and what kind of help, and that you stay with them emotionally, but it doesn't mean that you take on their pain. So that's point number one. So the contradiction when it comes to suicidality and the mixed message that I think this question points out is that, and I would rephrase, say, Dr. Amsel, you're giving us a mixed message, and I am. The mixed message is, on the one hand, this is something you need to be concerned about and you need to take it seriously. But I'm also telling you not to be afraid of it and not to worry about it, right? And not to be scared of it. And the beautiful thing about having this systematic approach is that you don't have to be fearful about the outcome, because you say to yourself, I am doing what I can do, right? This is a field in which the prediction of suicide is very, very difficult. I don't have to be a Superman or a Superwoman, but I do have to be very responsible to my patient. And by taking these steps carefully, putting aside any fear that I have and taking these steps carefully, then I am reducing any anxiety I have. Oh my God, what happens if this patient, I was responsible and I haven't done the right thing? Well, do the right thing. Set up these things, do with the triage, set up a safety plan, and then you're doing the right thing. And we have to leave it to fate. The ultimate outcome, we can't always 100% predict. But if you do this correctly, you're going to reduce that probability so significantly that there's a bad outcome. But that only answers half of your question. The other half of the question is about the emotional, being emotionally prepared for it. And I remember one time I was working in a study similar to this. Well, not similar to this one, similar in the sense that it was a funded study by the federal government. And we were screening people for post-traumatic stress disorder. But occasionally somebody very suicidal would come into one of these screenings. And I would be working in a clinic in the hospital. And what I would have to do is to literally call the security guards and have this person taken to the emergency room, which is a very unpleasant thing to do. Excuse me, sir, please sit here. I'm calling guards on you because I think you're gonna hurt yourself. And I would have to, ahead of time, psych myself out. I would have to say, yes, this might happen. I'm prepared for it. I know that I'm doing the right thing. I know that I'm saving a life. I know the person might be angry with me, but I know I'm doing the right thing. So that would be one instance in which I would have to psych myself out and and prepare myself for that. And that again doesn't completely answer the question, because I think the leftover part of that question is, how do you prepare yourself for just the emotional intensity? I think that many of us who've lived a life have had bumpy roads and have had moments where we ourselves have come close to the ultimate questions. Some of us in the clinical world, have had serious suicidal ideation, have made plans, have even made attempts on suicide. During COVID at Columbia, we lost people we lost some of our best emergency room clinician. Took their own life. And I would say it's no different in this than it is in other clinical situations where something may touch on your own thing. And that is, you don't have to share your own experience with patients, but you can use your own experience to understand them. You could go into the room and you can say, look, I've had this experience, and so I can use that experience to really understand where the patient is at. And so turn it around and say, yes, this is a little bit sensitive for me, but I'm going to be putting my focus on the patient and focusing on them and using my experience to be able to help them get through with it. And then sometimes, it's been my experience, sometimes when you'll encounter, let's say, somebody who's suicidal in a way that touches you, in a way that really makes you yourself feel vulnerable, I would say that's an indication for saying, I have to do more work on that. So this patient has come to me and has done me a favor. This patient has come to me and has pointed out that I am still carrying a hurt. I am still carrying a vulnerability. And for the sake of myself and for the sake of my work, maybe I need to go back and do a little work on that, whether it's with friends or whether it's with a professional. In the course of my professional life, I have found certain times where I had to go back and go put myself back into a therapeutic situation because something made me vulnerable or something made me realize that I have a vulnerability that I have not yet dealt with. Clinical work and life work are intertwined in that way. We obviously want to keep our personal lives out of it. This is not necessarily something that you share with anyone, with a patient. I have a whole separate lecture on when you share things about yourself and when you don't. The simple answer is it's very rare. There are moments you do it, but it's very rare. But I would say that sometimes if the patient's vulnerability comes up, you come to realize, you know, but for the grace of God, there go I. Or maybe there's a vulnerability that I need to shore up, that I need to do some work on. But thank you for asking that question. I think that takes great courage to put that question out, and I totally appreciate. I totally appreciate your participating at such a deep level. Thank you. Well, that.
Is there any other questions? Oh, we have somebody with a question over here. She's gonna come over just to make sure that you can hear her.
Hi, Doc, you just mentioned, if you share certain things, you're actually vulnerable. My question to you, can come to transference be used in counseling? Counseling someone who would have been exposed to suicide. And like, based on your research, like in the last 5 years, it would have been that. How was the percentage like, or what would have been the cause of suicide? Thank you.
Thank you. I'm going to ask Megan to repeat the question because somehow her mic is so much clearer than other people's. So
Yeah,
Megan, can you summarize the question for us, please?
So, if you want to just try to again. I got the block, I got it. So I think you got two ones. So the first one is that if you are counseling someone who has suicidal ideation, and I think you were saying like if you also have that experience, is it important that you also go seek counseling? Sorry, sorry, I wasn't clear. I'm not clear on the first question. But you know, I'm not sure. Okay, so I guess what that is one question actually now, a new question from the audience. So we have 3 questions. So if you have that experience and you know it might be potentially triggering for you, should you preemptively kind of think, okay, maybe I should be seeing somebody about this as well?
Yes, I would say that if the issue is sufficiently powerful inside yourself, that you find that when you're talking to a suicidal patient, it has, of course it's going to affect us, but you find, my God, that has a powerful effect on me. Then it's very important because you want to be your best tool for your patient. You want to be your absolutely best tool for your patient. And if that, and it would be very understandable if one has had experiences like that, that this could trigger that. But I think if you're in a situation like that and you find that you're triggered, that is very important to go and say, well, that's not sufficiently resolved. That wound is still open in me, and I need to, to go and have that wound looked at. I need to work on that wound. And I would go one step further and say, if you worry about it, if you think, okay, I'm going to go into a suicidal assessment situation and I'm even a little worried that it's going to personally affect me in a powerful way, if you're even anticipatorily worried about it, you should do something about it, because you won't be able to be your best self. You won't be able to be objective. You won't be able to be careful, so that you'll err on both sides. You might over err by thinking everybody is suicidal, or you might compare it to your own. I'm not talking about you now, but I'm just talking about a generic person might say, oh, when I had my suicidal ideation, it was so much worse, so this is not serious. I've seen clinicians do that, and that would be a mistake also, right? So you have to be careful that your own situation, recognize that your own situation helps you to be empathic, but it's also unique, and make sure that it's something that is, as nothing's ever completely resolved, but that it's well resolved. So it's well resolved in your own heart, so that you can come to the clinical situation. I'll use biblical language for a moment, as a servant of the patient. Okay, as a servant of the patient. I think you understand my meaning. So we have still questions number 2 and 3, Megan.
So two, if you could repeat
So
that again.
he's actually saying avoid using transfer.
Okay, so you're talking about using countertransference. Avoid using it, avoid using countertransference. Is that what you're saying is the second question?
Well, countertransference is a complicated word for most for most people. So so let's talk about that for a second. So transference is when a patient sees things in the treater, in the doctor, in the nurse, whoever is dealing with them that aren't there. That's transference. They see things that aren't there because there are things that their own experience that are brought in but are not necessarily. Countertransference is when the treating clinician does the same thing to the patient, i.e. they bring things from their own life, into that situation. So I wouldn't go as far as say don't use countertransference. I say be very careful, be aware of the countertransference, be very aware of it, and be very careful with it, because your countertransference, as you are pointing out so acutely, so wisely, that countertransference is a powerful force in the interaction. So be aware of it, let your mind feel it and be aware of it. Don't necessarily share it. Use it as part of your clinical strategy, and make sure that it's not so powerful that it takes over, your thinking.
Thank you. And then the last question was,
Because like in the last 5 years, there was a revolution wide right? And what
so in the last 5 years, Larry, to your knowledge, have there been any changes to the traditional factors associated with suicide? So have there been sort of, due to whatever reason, societal changes, et cetera?
Well, COVID, I would say that COVID has been a huge factor, and we know that COVID has affected mental health around the world, and especially for young people, meaning college age kids, but also high school age kids. There's been a huge mental health factor in it. To my understanding, there is debate whether or not suicide has gone up. Completed suicide has gone up during COVID. There are different pieces of research that point in different directions, but I think that has been a very strong factor. And I would go to one other thing, which is going to be my segue to my slides, because I think I want to give these last slides an opportunity as well. And a segue into that thing is that in those societies, and in those situations in which clinicians are recognizing depression and treating depression, suicidality goes down. And you'll see a slide about this very point. You'll see a slide, very strong slide about epidemiologic research that shows that in situations in which clinicians are recognizing and treating depression, the suicide in the society will go down. Unless there's a burning question, I am going to go back.
Question, but we can save it for what after you do these next slides.
Okay.
Yes.
And Megan, so thank you so much for your help. Are my slides visible?
Yep.
Am I still sharing?
Yep.
Okay, terrific. So let's talk about the boxed warning. So what is the boxed warning? In 2004, the FDA held a conference to examine suicidality in youth due to SSRIs, which are serotonin reuptake inhibitors, right? Things like Prozac, Lexapro, the mainstay of antidepressant treatment at the current moment are called SSRIs. So the question was, the drug companies who were trying to get indications for these were running these studies, and they found that there was an increase in some suicide reported. So they initiated a review of 24,000 kids in total. Now, be very careful to understand, these were kids who were in studies using SSRIs. There were no completed suicides in any of these 24 studies. I'm sorry, I read the numbers wrong here. It was 24 studies with 4,400 kids, not 24,000 kids. That slide is not, that slide number is not printed correctly. It's 24 studies, 44,400 kids. No completed suicides, which is very encouraging, right? But they did find that among the kids who were in the treatment versus the placebo group, that there was a 4% report of suicidal ideas. And these were spontaneous reports because these guys were not collecting systematic data. They weren't asking everybody in their study, which now seems nuts when I look back at it. But these were early studies on SSRIs, and they weren't systematically asking about it. But there was a spontaneous reports where people come in, oh, I'm having suicidal thoughts. And it turned out that those spontaneous reports were 2% in placebo, 4% on the SSRIs. So the FDA warned of a possible increase in suicide. It says suicidality here, meaning suicidal ideation primarily. And they called for weekly visits, but they changed that and they softened that after time. A review in 2007 said that the weekly visits don't have to be done as weekly. You have to use clinical judgment, but they did say be careful, and careful monitoring became the practice that was encouraged, which is a little vague. But clinicians need to use risk-benefit ratio to understand how to use SSRI. Oh, a risk-benefit ratio? That's what we do with every medication, right? When you give an antibiotic, there's a possibility that person could die because that antibiotic is an allergen for that individual. So we're always using risk-benefit ratios. So what is the risk-benefit ratio of using antidepressants? Well, first of all, let's say that SSRIs and SNRIs, those are selective noradrenergic uptake inhibitors. They play a key role in treating depression and anxiety. For those of you who were at my lectures yesterday, you will know we talked about the research that's involved in this. And if you weren't at my talks yesterday, I just have to say shame on you. You know, I'm sorry. Not really shame on you. I'm teasing. I just feel bad for you for missing those talks, because whatever talk you went to was not as exciting as mine. So that joke fell very flat, but let's go on. So we do know when there's we do know that our first line of treatment for depression and anxiety is psychotherapy, not meds. Unless it's very severe anxiety or severe depression, we recommend cognitive behavioral therapy as the first line. But if that doesn't work, or that's not available, then we do know that we recommend for depression, for anxiety, we do recommend these SSRIs and SNRIs. And there's substantial data that shows that these are beneficial, that these will help people in depression. And they will make a huge difference for people who are in severe depression. When people are in actually severe depression, as many of you are clinicians know, you can't talk to anybody. You can't talk to them and do cognitive behavioral therapy with them. So it's very important to realize that you can't do behavioral therapy. In those cases, you do need to use the medication. So what's the benefit? Well, children's depression rating scales. Let's look at this huge study. This was a very large federally funded study, and you can see there were 4 arms in this study, a combination arm which used both medication and cognitive behavioral therapy, one that used only the fluoxetine, one that used only CBT, and then one that used placebo. And you can see that there is a big difference here in the reduction of the CRS. So as these lines go down, it means the symptoms are going down. So you can see that on the fluoxetine, the orange line means that those people on medication had a huge reduction in symptoms, from a symptom score of 60 down to a symptom score of 30, and that those people who were in combination did even a little bit better. So that's a really important thing. People on placebo, yes, over time they got a little bit better, but not having as much benefit anywhere near. What about suicidality? Remember we said there was this increase at the beginning of these trials? Yes, that's true. But what happens if I go and I do a proper study in which I ask everybody about suicidality very systematically from the beginning to the end? And what you see over here is a huge decrease, right? Oh, from week 6 to week to week 12, you see a huge decrease. The gray bar here is one measure. It's the CDRS question 13 in the CDRS, which is a suicide question. And the other measure is the, I'm sorry, that's the SIQ. The CDRS is the green one. So both of these measures of suicidality go down hugely over 12 weeks being in treatment. So some people have walked away from the boxed warning with a message that, yes, it helps depression, but it increases suicidality. That is false. That is false. SSRIs over 12 weeks usually decrease suicidal ideation. Again, somewhere in the middle, there may be a little increase in some kids, 2%, but overall, it hugely decreases suicidality. Same piece of evidence. Again, this is the mean score in suicidal ideation in that other study that I showed you, and you can see, you know, the people who are on the medication, huge decreases. Okay, so what about the population effects? That's for individual. What's about the population effects? So following the FDA advisory in 2004, what happened? Clinicians stopped prescribing. They got scared. They stopped prescribing. There was a sudden drop in antidepressant prescribing. And what happened? What happened is, I want you to just look at the green line at, as an example. This is ages 25, 8, and 9, and you can see the actual rates. So what happened was that the rates of suicidality here, this is the expected reductions, not the rates, okay, but the reductions following the FDA thing. So you could see that we were getting improvement in the reductions in diagnosis. But here, this line without the boxes, that shows you what we were expecting to happen if people continued to prescribe, but they didn't. And so the reductions in suicidality fell off. In other words, we were making great progress, but when they put out the FDA warning and people stopped prescribing, we lost that gain. We lost the gain in all three of these age groups. We lost the gains that we were getting. There's less gains down here in the younger ages, but there were great gains. And here's our expected gains were in these lines without the boxes, the red and the green line. That's how we expected things to go. Oh my God, it's going to get better and better. And instead it reversed itself and we ended up having more depression. So here you can see just the rates of antidepressant prescribing. They were going up and up. This dotted line is the expectation of what we thought we would have in terms of the prescribing, and it fell off. The first and second things you can see, the observed amount of prescribing fell off tremendously. Well, what happened when that fell off? The suicide rates, which were going down. Remember, and the depression was going down. And look at the projected thing here. The suicide rates were going down among adolescents and youth. And here's what we were hoping. Here's 2004. The boxed warning comes in and the suicides go up. Okay. Boxed warning comes in. People stop prescribing the medication and the suicides go up, up, up. I hope that is very, very clear. If you're talking to parents, they say, oh, this causes suicidality. No. No. There was a small increase temporarily in the beginning of sometimes in the beginning of the study that I want to be aware of, and I want to follow my cases so I can catch those cases. But overall, to a huge degree, both in terms of individual studies of individuals and epidemiologic studies, with those of you who are into methodology know those are two different ways of measuring, you know, the signal in the population. But both of those will show you that the SSRIs, the use of SSRIs on a population level can affect the suicidality. And by the way, I think this is a good lesson for Guyana. I'm not familiar with the details I'm about to talk about. I'm not familiar with those in Guyana. I'm getting more familiar as we're doing our study, but it does speak to the idea that if we help mental health professionals, and if we help primary care doctors to recognize and treat depression, both with medication and with CBT, as I mentioned, we will get back on this red line. We will decrease suicidality. This is, again, American statistics, but I'm just saying, imagine this happening in Guyana, where we reduce suicide rates. Why? Because we're catching depression, and depression is a major, not the only risk factor, but a major risk factor. Okie doke. So I come to my summary slide overall for both parts of the talk. A careful assessment of suicidality is critical, whether or not you're prescribing SSRIs. Discuss and develop a suicide safety plan for all depressed patients and patients with suicidal ideation. I'm going to jump in here and just add that no, I'll save this. I wanted to talk about non-suicidal self-injury. I'll talk about that when I finish this slide. Families and patients need to be fully informed about the potential for suicidality. And you know, this is like everything else we've discovered. If you talk about it, it gets better. If you avoid it, it gets worse. Drugs, sexually transmitted diseases, HIV, all of those sensitive things. We're professionals. We have to communicate that, yes, to a lay person, this may seem like a very delicate and sensitive topic, but we're professionals. And you have to communicate that you know about this, you're comfortable talking about this, and you give them a chance to be comfortable talking about it. Remember that trick about normalizing. Say, my other patients tell me, okay? My other patients tell me that they have an incredible urge to stand on their head. Do you ever feel that? In other words, get used to formulating your questions in that normalizing fashion. Families and patients need to be fully informed. Your patient's going to get this suicide plan. He's going to have it with him. The next time he hits a crisis, he will use that plan. And you're going to check in with him, and you're going to say, did you hit a crisis? Did you use your plan? And if the person says no, you say, come in, we got to talk about this. You know, the only reason I feel safe with you out there is because you have and you're utilizing your plan. Discuss potential benefits and risk of SSRIs for depression and anxiety. As again, when cognitive behavioral therapy is not going to work for them. And partner with caregivers and monitor, be aware of sudden changes, be aware of what we used to call compliance. I think we now call this adherence, which is, are people taking the medication? Are they using the plan? Are they doing the things that you have advised them? And if they're not, don't blame them. You know, sit with them and have a conversation, have a non-judgmental conversation. Be aware of adverse events and be aware of emerging comorbidities. And that's the last slide. We're into the, thanks for your attention, folks, but we are into, we have a good time left over for Q&A, right?
Yes, so we actually have one question that was in the chat that I didn't get to read before, from Kelly Dijon, and she says, good morning. What if the child doesn't want to open up during counseling sessions after an attempted suicide? How do you cope with a situation like that?
So what you have to think in your mind is, if you should be doing the screen with that child. So if a child had a suicide attempt, if a child had a recent suicide attempt and you're now seeing them in the office, you need to do the suicide screening test with them. And remember, when we do the suicide screening test, if they don't answer, then the answer is yes. If they don't answer, the answer is yes. You have to score them as a yes. And I want you to think about it this way. Imagine something bad happens and someone comes over to and reviews your records and say, how did you do this? And you say, well, the kid didn't answer any of my questions. You know, that's not gonna fly, you know. So you have to assume that if the kid's not opening up, that they are answering the questions in the worst possible way. Does everyone understand what I mean? The worst possible way. They're saying, yes, I have suicidal ideations. It's just like saying, yes, I have a plan. I don't want to do that. Also, I would say, and I know that this is so hard with the resources though, but after an actual attempt, kids need to be in very intensive care. Preferably in an inpatient unit, if that's possible, or in a day care program. You need to really be sure that the suicide crisis is over. Now, it's interesting what happens. This is just clinical experience. I don't have data to back this up, so be careful. What I'm saying right now is not evidence-based. It is anecdote-based on my own anecdotes. And that is that for some people, after they've made a suicide attempt, that ends the suicide crisis. People, thank God. The first question you ask is, are you happy that you are still alive after your attempt? If anyone says no, I'm not happy, they need to be in a hospital. Someone's made an attempt and they don't say, I'm happy I survived. That person is at a very high risk for repeating the suicide attempt. And that's the way we lose people. But even if they say, yes, I'm really glad I'm alive. So for some people, it's really true. They're very, very glad they're alive. And for some people, what I call the suicide crisis is over. But for other people, it's not. They say, I'm glad I'm alive, but it's fluctuating. I still have terrible thing. My wife is still leaving me. I still lost my business. So those people, you need to be sure that they are. I like to keep them in the hospital for as long as the hospital will let me, till I'm sure that they're over the suicide crisis. What do I mean, the suicide crisis? Whatever was driving that suicidality. Now, let's say somebody is getting a divorce and that's what's driving the suicidality. Obviously, you can't reverse that. You can't say, okay, well, we'll wait until he remarries or until they resolve the divorce. No, but until the person makes peace with it, until the person has come to some kind of peace with it, or at least enough peace that they can imagine living. But as long as they're saying, I cannot imagine living if my wife goes, I cannot imagine. I had a review case like that as an expert witness, where this guy kept telling the clinicians that if his wife leaves him, that he will not be. And she was very sensitive to him, but nevertheless, she had to go. And what happened was that they let him out of the hospital, and he went home, and she said, yes, I am leaving. I told you I'm leaving. And he had been in denial. And when he finally heard that she was leaving, 2 days after leaving the hospital, he hung himself. Why? Because that crisis was still active, right? He had not made peace with the idea that he could survive the divorce. So that's the answer to the question. But I want to go back and say that I went to part 2 of my answer before I did part 1 of my answer. Part 1 of my answer, which would have been a much better way of approaching the thing, is to start with is use these techniques, gentle techniques, to try to open that person's up to speaking. Before you jump to the second conclusion, like you say, okay, they're not answering, I have to assume the worst, but you can use those techniques. And if any clinicians here are not familiar with the techniques involved in something called motivational interviewing, I strongly recommend that you get a book or just watch a tape. I'm not telling you to take a whole course in it, but do become aware of some of these techniques, because they are really helpful techniques. And these are techniques that help open people up, and it's called motivational interviewing. It uses techniques like empathy, like feedback, different kinds of technique that make it more possible. So what is it? It's you've all watched master clinicians sit down with a patient who won't talk to anybody and get them to open up. And so what I would say is you always can improve your own skills. And the first thing to do with a kid like that is to try and get them to open up. And one concrete example I will give you is the first thing you do is you talk about the elephant in the room. You talk about the thing that no one's talking about. So you might say, oh, Johnny, you're not answering my questions. And I'm sitting here, I'm really wondering what it must be like for you to sit and be mute and not answer and sit there and sort of tightly hold on to the thoughts in your head and not share them. I'm wondering how that feels. So acknowledge the elephant in the room. Acknowledge what's going on. Don't try to push the kid to answer. Acknowledge what's going on. When I was a young resident, once I had this patient who was a schizophrenic patient, and we'd have these sessions, and he wouldn't talk to me. And my supervisor said, "So what does it feel like?" I said, "It feels like I'm sitting with a potato." And my supervisor said, "Tell the patient that. Tell him that." I said, "What are you, crazy? I'm going to tell this poor schizophrenic patient's got enough troubles. I'm going to tell him it feels like I'm sitting with a potato." My supervisor said, "I'm your supervisor. Tell the patient that." And so I go into the session, I tell the patient, we sit quietly again for 5 minutes. I say to the patient, and I was shivering at this point, I said to the patient, sitting with you, it feels like I'm sitting with a potato. And the patient turns to me and he says, "Yeah, that's how I feel." How did you understand that? That's exactly how I feel. So so saying what's going on in the room is always magic. Next question. And thank you for that question. That was such a wonderful question. I think you really helped everybody learn by asking that question.
Does anyone have any questions from the audience or from the chat? Oh, okay, you wanna come here? Yeah. you can come up here.
Alright,
Oh,
so
actually, you're close to the mic, you should be good.
as it relates to teen and teens and young adults, when this evaluation is being done, is it wise to have a parent or guardian there? with
Pardon?
them?
I'll talk to them. You can leave this, yeah.
I'm sorry, there's interference. I can't hear the question.
So he's asking.
Megan, if you tell me the question, it would just,
So, and what's your name, sir?
Jonathan.
Jonathan. So Jonathan West is asking, his question is, if you're asking a child's question in a therapeutic setting, is it wise to have the parent there?
great question. Wonderful, 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 wonderful question. Depends on the age. Number one is it really depends on it depends on the age of the kid. But number two, I would say that you start in questions like this. It depends on you can see the relationship with the parents and whether the kid's comfortable with the parent. But I would say, send the parent out and start with the kid and start talking to the kid. And then sometimes the kid will say, "Are you going to tell my mom and dad?" And the answer is, at least in the United States, the rule is that everything is confidential unless it's potentially dangerous. So you say, "You know what? I have to be honest with you. The answer is I want to talk to you about these things, but if it's something that's dangerous, I will have to discuss it with your parents." Now that's somewhat inhibiting, but it's still I think better is you have the kid alone and you ask them these questions, and then if there's any kind of worry, you sort of very gently say, "Look, I know that it's hard for you to bring your parents in, and I don't like to violate your confidentiality, but we're in a danger here, and we need all hands on board. And I need to bring your mom and dad in, and we need to let them know about this because we need everybody to work together as a team." So I would say with a lot of kids, with most kids, you're going to get more if you talk to them alone, even after you tell them that you'll have to share the stuff with the parent. Even after you tell them that, they still might be more willing to talk to you alone at first, and reveal these things. And what you can do is you can serve as a mediator between that child's fear that the parents are going to be angry and the parents. So you could say to the kid, "You know what? Yes, we're going to bring your parents in, but I'm your advocate. I'm on your side. I'm going to explain to them, you're not doing anything bad. You're a good kid. I will explain." So the kid can see you as an advocate. Things that the kid might be afraid to tell his parents on his own, he might be much more comfortable with you communicating. Most parents are not going to blow up in the room or say, I know it's a source of tension between you and dad. He doesn't really get your depression. But I will help explain it to him. I will help him understand that you are trying your best. So if you can let the child know that, you're in the courtroom as their advocate, right? You're their lawyer with the parents. Does that help your question?
Yes, it does.
Yep. I think we have time maybe for one more, and then I think that we're at the break. If anyone else has a question that they would like to ask.
How do you guys get me coffee? I don't understand, through the Zoom. How do you do that?
Okay, last call. I'm coming. Oh, in the back.
Oh, and Megan, while we're talking about, so how many people are in the room over there? I didn't realize
It's a
there were
packed
people.
house. It's a packed house. We got 3 rows full.
Oh, wonderful. Oh, wonderful.
30 to 30,
Wonderful.
yeah.
I'm glad to hear that. And I hope this was helpful.
Yeah.
So if parent is like, let me say that parent is giving you some, what do you do then? Do you
Yeah.
get like another person that can look over the child or maybe put the child in a mental space?
So,
What do you
what's your name?
talk to them, especially if the child is on the age?
What's your name?
Your name,
Janisa?
yeah.
So Janisa wants to know, what to do if the parent is the abuser.
If the parents
So-
what?
If the parent is an abuser, so, and the child
What?
reports to you, who do you talk to?
Well, if the parent is abusing the child, then you have to get the child away. So the child needs to be protected. That's your first goal, right? your first goal is that the child needs to be protected and needs to either be gotten away from that parent, or there needs to be, you know, there needs to be a social intervention. There needs to be a social intervention. So what do you do? It's a very, very, very tough. It's a very, very tough situation. And depending on the parent, the main parent could be really an obnoxious. Obviously, they're obnoxious if they're abusing their child. But
Yeah.
let me. I'm just trying to come up. Trying to phrase. I'm trying to phrase this correctly.
The case where I'm trying to say, like, the child may not be comfortable telling you what's wrong. It's not the parent, you might want to bring the parent in the room with them, especially if the child is not age.
So if the child is underage and
And they don't want to speak in front of the parent.
they don't want to speak in front of the parent, is what she's asking versus.
No, I said that. So that was the reason I said that you try to get, you try to get the child alone. You get the, you tell the parents, I need to speak the child alone. And if the parent is abusing, for example, if a father is hitting a child or something like that, they will often be quite resistant. You know what I mean? They will often be quite resistant to your talking to the child alone. And depending on the situation, you sometimes have to get quite tough. You could sometimes say to a parent, I need to speak to your child alone. I don't want you to talk to my child. If you don't let me talk to your child, I'm going to assume the worst here, sir. I'm going to assume the worst. So, you need to get that child. You need to protect that child. That is the first. That is the first. That's the first order of business. But protecting the child doesn't necessarily mean being mean or cruel to the parent. You need to make sure that the child is protected, and it is a police and social service responsibility to protect that child. You have to get them involved. They have to protect the child. In some cases, they have to punish the parent. I mean, that's a social obligation. You can still be a helpful person in the parent's life. You can still say, this is terrible. We have got to protect your child and take it away. While I totally don't approve of your behavior, and I'm going to have to report this, like in a family situation, you might say, but even though you may be going through some legal problems, I can be here for you because I know ultimately you don't want to be doing this. So you can also signal that you are a resource for that parent, not to protect them from their legal consequences, and certainly not to stop them from having this child taken away, but that if they are willing to face those consequences, they're willing to do what's necessary for the well-being of the child, that you haven't canceled them, right? You haven't canceled them. That you as the family, as the clinician to the family, are willing to talk to that person and to work with that person. Very situationally dependent, obviously.
I think you have another addition. So what did you want to say?
The reason I asked that, I know the case where a child was forced to speak in front of their parents and thought the story, and that led to the child attempting suicide after because the child was fearful of their life.
So by the clinician, they were forced to talk. Okay.
And the police officer.
Wow. Okay. So a child reported being abused, and they were forced to disclose that in front of the clinician, the police, and with the parent in the room. And then the child attempted suicide. So this is the case that we're talking about.
Yeah. So again, I would say, I would say that I don't want to interfere with police procedure or other things like that. As a clinician, I would say that was inappropriate. That the child should not be forced to do that in front of a parent. You do want to get the information from the child, but that should be done. That should be done separately. That really should be done separately. Ideally, the child report separately. And again, there are three priorities in the following order. Number one, safety of the child is number one. Nothing else matters. Number two is you make sure that whatever legal and justice thing takes place, that if the parent has committed a crime, or if the parent needs to lose custody of that child, that has to take place. And then priority number three is such a family, if they're going to, such a family that's traumatizing for them. It's traumatizing for the child. It's traumatizing for the family. So you have to sit down and make a plan. You know, maybe all of this happens. Maybe the child has been sent to foster care, but maybe at some future point, first of all, be aware that that is a trauma for the child, so that you're following the child, asking them questions about their own suicidality. And also you can say to the child, look, we're going to do a family therapy. We're going to do a family therapy. You know, of course, mom and dad are a little bit upset that you told, but you did the right thing, and ultimately they'll understand it, and we will try to do, you know, a therapeutic situation over time in which we can, even though you're going to be living in foster care now, we can try to help improve, you know, that your relationship with your primary family. And again, I hesitate saying that because it depends on all these legal situations. There might be orders of you know, in which the parent's not allowed to see the kid. But I just want to say, you know, in other words, be compassionate to the kid, and be compassionate to the fact that maybe there's some healing possible in that family, and let that, you know, the kid know that that's a possibility. And you have to work with the kid and let them know it's not their fault. I mean, you know, a 7-year-old, you know, in a situation like that, a 7-year-old will take on the responsibility of the world. It's like some kid thinking he's responsible for the war in Ukraine. I mean, the amount of burden that a child will take on if they've had to report on their parent is almost an unbearable thing. So your point is so well taken. That child needs to be followed very carefully, as to what their mental status is, and how they're processing it. And again, sometimes maybe, you know, a phone call with the parent, where a parent, you talk to the parent, and the parent will say, look, I'm calling up Jimmy, and I'm saying, Jimmy, I know you did that because you had to do the right thing. I'm proud of you that you did the right thing. If you can get the parent to kind of ease the child's guilt, that would be wonderful. But it's very, I know I'm throwing out different ideas. They're not all consistent because it's very much situationally dependent. But what a great and challenging clinical situation you brought up for discussion. So I appreciate that.